super excited to share my investigative journalist cheese toasty. We're talking CFS, cancer awareness, HIV, AIDS, injustice, long COVID, accountability, science and media with George Monbiot and David Tuller. Oh look, we've got my little... They do that, don't they? Clever people put their bookshelf in the background.
Right, let me just sort this out. Are we live?
No, don't worry, we're not live.
Oh, thank God for that.
But I've got the recording, George, so I can use it against you.
Yeah, try. I was just thinking, this is where the entire world sees how totally incompetent I am.
So I'm used to having sound department, hair and makeup, crew.
Well, sorry about this.
While George flirts with his cheeky mic, David interviews me.
First got sick when?
Oh, I first got sick in, a year before the pandemic, ironically. So I was fully bedbound, give or take. There were fluctuations, but yeah, mostly bedbound, I should say, for a year before COVID kicked in, which of course we knew that off the back of COVID there would be more cases of them, unfortunately.
Right. I mean, that was so clear. I mean, that was, people were writing that, including me in April, say that there was going to be a wave of post-viral cases with peculiar symptoms that were going to be hard to figure out what they were, and they were all going to be told that they were psychosomatizing or that they had psychological issues. So it was entirely predictable. In the US now, it is post-acute infectious syndrome. So that it's after the acute phase, but post-acute infection syndrome does not suggest necessarily that the infection is over. It's just post the acute part of the infection. So it sort of elides the issue with post-viral, which suggests that the virus is gone. So they don't really know.
Absolutely. I mean, and we know now with the biomedical research, largely off the back of long COVID, but there were several groups of really great scientists working on the ME front before that, where, we know what a virus is capable of, and not everyone has the initial viral infection to go off with ME, but, a large portion of people do. So it was all expected. But the great news is our mainstream media, especially off the back of Maeve Boothby O'Neill's inquest, I think has done a really extensive and good job at reporting what ME is and what the changes are that we need to make.
Yes, although what it's not done is showing any capacity for self-criticism and recognition that actually the mainstream media has been a huge part of the problem here.
Nice. George is back with us and a mic drop.
I mean, George is much more knowledgeable about the political interplay between media here than I am. But I've been surprised at all the media coverage. There's been very, very little appearance of Michael Sharp, Simon Wesley, all those people who did the Pace trial and support the Pace trial, except for one really bad column in The Observer by Alistair Miller, who's an old-time biopsychosocial guy. They've been pretty absent in the coverage and in commenting on it, which I find interesting. I don't know what it means exactly, but it does suggest to me that the media is taking this seriously in a way that they haven't before, and don't feel the same knee-jerk response to go to the opponents and say, well, what do you think about this young woman dying?
I think you're right, David. I think we are now seeing a turning of the tide, and far too late. I mean, this should have happened years ago. And the media has been massively culpable here, unfortunately, and it's been misled. That's part of the problem, and journalists are incredibly gullible people. David and me, I mean, David's also an academic, but we can say that our profession has certain flaws which are quite common within the profession, and you can sell anything to a journalist. If you were to judge people's gullibility by profession, journalism would be right out. It's one of the most gullible of all professions. And I think there's reasons for that. I think partly it's that people are on really high turnover rates and short deadlines. And so they don't really have time to think. Very often, there's just not time to think. I was very struck by, there was a a Victorian's, it was sort of like a social attitude survey in a way, but it was done in the 19th century. And they were interviewing factory workers, I think in Manchester. And one of them said, talking about these horrendous hours which people were working. And she said, the awful thing about these hours is I don't have time to be good. And that really hit me. It sort of jumped out from this whole report. I don't have time to be good. And I think that's a huge part of the problem in the media, is that, unless you've got time, unless you can really dig into it, read the scientific papers yourself, see what so all sides of the debate might be saying, understand it yourself, then you can very easily be steered and misled by people who've got a particular angle, who can sell you a bill of goods, because you just don't have time to do it properly yourself. So, for instance, the article I've just written, I've finished it yesterday for The Guardian, which is about ME, CFS and the media, and it's pegged to Maeve's death, and well, to the coroner's second report on her death, the Prevention of Future Deaths report. That was 10 days of solid research to get to the point where I felt, with the help of David and other amazing people, Sean as well, Maeve's dad, and, other people who I've spoken to, but just reading, massive research, and ending up with a massive, great file of compiled notes, just to get to the point at which I thought, okay, I've more or less got my head around this.
George Monbiot's article is now available in The Guardian. Sarah Boothby, Maeve's mother, comments, "This is how propaganda works, to favour those who understand military tactics and deploy them in order to achieve nothing more than their own personal ambitions. We, Maeve and I, knew about it. We, Maeve and I, tried to engage award-winning journalists in exposing it, and our democratically elected representatives in ending it. I'm still trying to find human rights lawyers to challenge it. None of them did, have, or are engaging with either her then or me now."
I think another thing to add to George's point is that one of the things that's happened a lot in the US, I was a reporter at the San Francisco Chronicle for 10 years, and I had a lot of health experience, but I still made mistakes because I didn't have any training in health or public health. I mean, I got public health degrees later, but after 10 years, I had a lot of experience. So I knew more or less what I was doing. And what I find with a lot of the research that I've criticized is that so many of the studies are observational studies, and they interpret every association as a causal relationship in the direction they prefer, if that makes sense. So you may find people who have ME have high levels of depression and anxiety, but you can't assume from that that the levels of depression and anxiety came before the ME. It's very understandable that people with ME or with an illness or long COVID that other people don't understand, or that their spouses say, we don't get to work or exercise or whatever. Of course, they're going to have higher levels of depression and anxiety. And of course, after the fact, the depression and anxiety are likely to exacerbate everything because they do. But you can't make an assumption or a determination from that the anxiety and depression were antecedent to the illness. There's a relationship between them, but most of the studies, many of the studies, you can't tell what direction the relationship is. And these people that I've been criticizing always like to interpret the studies in the direction of their preference, not of what they already believe. And I pointed this out many times in many studies. This is different from the criticisms of clinical trials like the PACE trial, where it is an experiment and they've done other ridiculous things that essentially make it research misconduct at a high level. So there's lots of messes going on in the research, and if reporters aren't attuned to that or aren't really experienced in reading studies, as George suggests, then they're going to get it wrong.
I do believe that in line with the biomedical research to date off the back of long COVID, the journalists are becoming more attuned to what they need to. And it was only the other day I was talking to geneticist Professor Chris Ponting from Decode ME, who very clearly stated we can see ME in the blood. I mean, there's a headline if you want one. I completely appreciate it's preprint, not peer reviewed, but they can see chronic inflammation, liver disease, and insulin resistance. And the old debate, like you've done an excellent job, David, of debunking the Pace trial. I mean, it's almost laughable. With journalists like you and obviously George, who, you know, British investigative reporter, political activist, environmental activist. I mean, you've been a columnist for the Guardian for what is it, 30-ish years? Should we buy you a cake?
Something like that, yeah. And I've been working as a journalist now for 39 years. It's ridiculous. Yeah.
Right. But when
Yeah,
you
we're
write
old,
something
we're
like
old
what you
people.
wrote in The Guardian, and you know, it's why you've been invited here today because I'm stealing words off you, David. It was a blistering takedown, indicting Wesley Sharp and the rest of the Get CBT brigade. But you know, you very astutely discredited, as David has done, their damaging theories about misleading, fraudulent research for ME. And I really do feel and can see with the mainstream media it's moving in the right direction. We just need to keep on it. This is a great plot twist. It's fantastic.
Yeah. Of course, you know, by comparison to David and by comparison to you, I'm a total amateur here. I mean, I've got a science background, which is always helpful. You know, it's always useful to understand what science looks like and how science is done. But you know, what we've seen with some of the worst cases of reporting on MECFS is actually by science journalists, experienced science journalists. So it doesn't necessarily insulate you, protect you from making an absolute idiot of yourself. Of course, we're all capable of that. But I came into this kind of accidentally, really. First of all, I had what the totally mildest end, but what technically classifies as long COVID, because I had COVID for 14 weeks or COVID symptoms for 14 weeks, and I was very frightened that I might not get better, as many people haven't. But for 14 weeks I couldn't get to the end of the street, and I thought, is this going to be my life now? And I was incredibly lucky that I got better. I feel so grateful. There's scarcely a day goes by when I don't think I'm so lucky that happened. But what it did was to open my eyes to the suffering of people who had both long COVID and MECFS. And it's obviously, as we know, quite a lot of overlap. We can't say they're exactly the same thing, but in some cases they do seem to be the same thing. And so I started researching that and found out just how shockingly, outrageously MECFS patients had been treated. I had a couple of friends who had it, and their testimony to me, but also the reading I did, and I started talking about it on social media, and I got these most horrendous stories coming back, just outright medical neglect, and people not being taken seriously, people being gaslit, people having to fight for benefits, people being threatened with being sectioned, people being put in psychiatric wards. This really, I was absolutely gobsmacked, and the sheer scale of it, the scale of this suffering of hundreds of thousands of people. And so I started off writing an article detailing some of this, talking about how long COVID could just add massively to the number of sufferers. And for God's sake, we've got to pull ourselves together and sort out this medical scandal and address this huge neglect. And one of the results of that, the most bizarre result of that, was that Professor Michael Sharp from the Biopsychosocial School, he did a presentation, I think, for insurers, at which he put forward Swiss Re, yes, for Swiss Re insurers, and he put forward this thesis that basically by talking about long COVID, you were spreading it. And he said, here are some of the super spreaders of long COVID, and my name was at the top of the list. Now, this isn't great policy. You take on quite a prominent journalist, and get the bit between his teeth and accuse him of doing something incredibly serious, which is causing many people's diseases by putting this idea in people's head that they've got the illness. And it was just like, whoa, this is amazing. And it's off the scale ridiculous. So anyway, I thought, well, let's look into this. You have to give it, as a journalist, you have to say, well, maybe there's something in it. So, let's see what his references are for this. Tumbleweed, nothing at all. Absolutely zero. No scientific backing whatsoever. So I got hold of him, again, the next thing you do as a responsible journalist, and I said, where's the references? And he just gave me some flannel, just pure blah. I mean, no references, no scientific support for his claims whatsoever. And then he said, I don't have time to talk any further. And so this was it. I thought, right, okay, this is clearly total bollocks. I mean, it did give me a sort of frisson of concern at the same time, because I thought, what if he is right? Because, I've spent my whole life writing about bad stuff of all sorts, mostly environmental, but all sorts of other bad stuff. And everything I've written about has got worse. What if I'm the cause? What if I did this? What if I've caused more human suffering than the entire cast of Alvin and the Chipmunks, right? This was a thought that went through my head. But then, as I started peeling back the layers on this, this is more and more ridiculous. I'm being gaslit now after years and years of all the ME/CFS patients being gaslit. I'm being told this total bollocks that I'm spreading long COVID by talking about it. So, if this is a standard, this is a way that school of thought operates. These people who are supposedly scientists and doctors, with this huge duty of care towards patients, towards research standards. And what else is going on? What else aren't we seeing here? And as I began to dig into that and started writing about it, I realized that it was, and I'm not the first to say it, the greatest medical scandal of the 21st century so far.
And my response to that, when Carol Monahan said that, I wrote to her, I said, Carol, don't you think that's a little modest? Shouldn't we call it the biggest, one of the biggest scandals of the new millennium? Even though it was, only 2000 and whatever. But I think, it is really, what I find astonishing is that the PACE trial is such a piece of crap. It's so filled with ridiculous flaws and nonsense that you cannot do in scientific work. And I've called it fraudulent in the sense that it's really manipulative and deceptive. And I'm not saying it's fraudulent in any legal sense because I'm not a lawyer. But it's fraudulent in the sense of it's just incredibly a deceptive piece of work. And that this piece of crap has been accepted at every level of the establishment, defended up the wazoo by Richard Horton, the editor of The Lancet. Patients slimed for criticizing it. I was slimed for criticizing it. Michael Sharp has presented himself as a scientific martyr here and there and made, accusations that are absurd, that he, about his harassment and whatever, and they have such a low level threshold that any criticism to them that they don't like, it seems to constitute harassment. And so there's been just an incredible amount of the entire, academic, medical, industrial complex in the UK and around the world. I mean, I don't exempt the U.S. Centers for Disease Control because they cited the PACE trial for a long time until eventually it became clear that it was ridiculous to do and they stopped doing it. But that this has been accepted as quality, super science by the top people in UK medicine. I find it absolutely astonishing. I showed it for 10 minutes to my colleagues at Berkeley, and they're like, oh my God, you have to write about this. I have a public health degree, but I'm not an epidemiologist. I showed them the PACE trial. My epi colleagues started using it in graduate seminars for epidemiology students. They would give them the PACE trial for a couple of weeks, and then they would present to the class how horrible it was. I mean, the students would come up with all the reasons why it's horrible. And you can't really tell, it's hard just by reading it. You have to read the protocol. You have to read, all the background documents to it. You have to sort of understand how they changed their outcome measures after they had collected data. All the things that they did, it requires actually reading not just the paper and not just going to the Science Media Center for their ridiculous press briefings, but you have to actually be able to look at the documents, related to the trial, like the protocol especially. What did they say they were going to do and what did they actually produce at the end? And so my colleagues at Berkeley were so shocked by this. And one of my sources, a biostatistician at Columbia, said this, is the height of clinical trial amateurism. And actually, Michael Sharp later wrote to him and said, I read on the internet somewhere that you said this thing about our trial. Why would you say that? And so this guy, Bruce Levin, and said, I got this message from Michael Sharp. What should I do? And I said, write him back and say, yes, of course you said that because that's what you think about the trial. And then I wrote to Michael Sharp myself and said, Michael, I understand you're checking with my sources to see what they said. I said, I'm happy to give you the email contacts of all my other scientific sources who also said terrible things about your study, and you can check with them if they actually said those things. And I got a response from him, which was, whatever, and that was the end of my last contact with him. But, these people are really, have done really just terrible work. And I understand at being at a certain age, they're in, Michael Sharp is probably not, I'm 68, so I'm probably more or less the same age. It'd be very hard to be told at the end of, towards the end of your career that everything you've done for 30 years is not only bad science, but it's actually been really harmful to people. So I can understand their inability to actually acknowledge their errors. What I can't understand is everybody else in the scientific world accepting this. All the scientists in the UK and everywhere else who have pretended for years that pace is normal and that it's okay. It's not. It's terrible.
It's not okay. It has been debunked. The NICE guidelines in October 2021 changed, thank God. They're still not being implemented, but I can see it all turning around, and that's the narrative that we now need to drive. How can journalists push the narrative that has taken a turn? Maeve Boothby O'Neill has opened this window, she's unbolted it, and there is undoubtedly light shining through. Ironically, it's shining through on me right now. Woo! So, moving forward, that is the direction we need to take. And David, your work has been absolutely sterling and provided people like George with his platform to go, right, here it is all laid out. Let's move on and give a really good example to other journalists how we go about this the right way. Interval time, 10-minute break for a lay down and a Kit Kat here, or a cup of tea and a soggy biscuit. You'll get the cookie joke by the end of the second half of this interview. On the subject of baked goods, please join in our Halloween bake-off. Enter by midnight on the 31st of the 10th, 2024. We do offer a collab baker if your chronic illness prevents or limits you from baking. Just email us. The email is bakeforme.social@gmail.com. And if you give us a photo or description of the cake you would bake if you could, then we will sort that for you via a buddy baker and it will be your entry. I want to use this opportunity to say a huge thank you to the Vikings Queens who have joined me on the judging panel. So yes, we will see all of your bakes. And no, you don't have to be a really good baker to join in. It's just a fun, light-hearted way to raise awareness for this cause. I'll put the link in the description, and for anyone listening, it's www.bakeformecfs.com. Stay tuned for the second half.
Hello.
We're back in business. Okay, so I think we have well and truly established on behalf of the PACE trial and all those associated, the jig is up. And, it's words that you guys used, and it's why I wanted to invite you both to speak. I feel now the real question is, what's next? What can journalists do to utilize this window of opportunity?
Except that this is an illness that is not driven by psychological factors and by anxiety and by post-traumatic stress disorder, although, of course, those things can exacerbate any condition. And anybody with any condition can benefit probably from some supportive care and supportive therapy relating to those aspects. One of the things I did want to say was that what's astonishing to me is that for the most part, ME/CFS has appeared sporadically, like someone gets sick and then they don't get better. Occasionally in what we see sort of mini epidemics or small epidemics, like in Lake Tahoe in the late 1980s. But with long COVID, we have something really different. We have a worldwide phenomenon where in every country where this is happening, people are staying sick. And so we have a worldwide natural experiment of, a global phenomenon where the same thing is happening to many, many people after their acute bout of COVID. And you can either have two kind of perspectives on that. Either we have mass hysteria on a global scale, and all these people, all these lawyers and doctors and actresses and who are working and love their lives have suddenly have so much anxiety and depression and PTSD from the pandemic that they suddenly can't do any of the things that they loved doing before, and they just need psychotherapy and some exercise. So that's one road. Or you can think, gee, these people have long-term illnesses, and we've known forever that after viruses, there's some people who continue to report chronic symptoms, for long term. And we can either assume that there's a mass hysteria on a global phenomenon, unseen before, or that people are actually really sick and need medical help. I don't understand, except if you're based on all your pre-existing prejudices, why you would think it's mass global hysteria rather than an actual pathophysiological phenomenon that's going on with people. But they're still publishing the same ridiculous studies. And I still have plenty of studies that I find that I can criticize that are positing these things either about ME or about long COVID. And so, yes, on the one hand, I think there are a lot of people seriously looking at it. On the other hand, those troglodytes are still pursuing their troglodyte work, which isn't really valid.
Yeah, and the stigma that's attached from the old stuff, unfortunately, is still bled into
Yes.
hospitals, etc., and people not implementing the new nice guys.
Right.
I always say I've got a frog in my brain called Brian. It's my brain frog. He just skips in every now and then. The new nice guidelines. So I completely am with you on that, and I do think we now have to do this fine art job of balancing talking about the history with, okay, what's new. So just as an example, and please, if neither of you want to talk about it, that's absolutely fine. October is obviously Cancer Awareness Month, Breast Cancer Awareness Month, so I've got a pink hair bobble in, and I know that George, you have had your experience with cancer, and I also know, separate to that, obviously David, you were writing about HIV and AIDS before you pivoted to ME/CFS, and the reason I bring those two subjects up is because the science I've read to date involves both of them with ME and, infectious disease. So, David, would you mind if I hear from you about your experience writing about HIV and AIDS? And just to give that a little bit of background as to why I'm asking, Dr. Henrik, he's been deploying, it's a USA scientist, the LINK study. I'm not sure if you've heard of them, but he, from the very beginning, Dr. Tim Hendrick, it could be Hendrich or Hendrick. They're the LINC study, LIINC, and they've been deploying their resources for HIV to study COVID-19 and the long-term effects pretty much from day dot. They've come really far with it, so much so that they're looking to start a clinical trial of repurposed HIV antivirals in long COVID. And the science is really cutting edge and fantastic. So I just thought it would be a great opportunity to talk to you about HIV and AIDS in line with that.
Yeah. Right. So, I'm 68. I'm a gay guy. I'm from New York. And so I returned to New York after college in 1979, essentially. And so I was just sort of figuring my way. And then by 1981, we started hearing about all these diseases. So basically my 20s and my 30s. And then so I was very involved in activism in New York. And then in 1988, I moved to San Francisco and became a reporter for the San Francisco Chronicle. So I could no longer, you're not supposed to, George is an activist in a way, is whatever, but activist seems to have a dirty word, is a dirty word a little bit in the UK, or campaigner. So, if you're a mainstream newspaper reporter and not a columnist, you're not supposed to be engaging in advocacy activities, especially since I was covering HIV. So in the 90s, I was mainly covering HIV. But the other thing is that, it was my entire life because everybody I knew was dealing with it. I had a partner who died in 96, people dying all around you. So I was an AIDS activist, for a while. And people sometimes said, oh, now you've, switched to this. And I actually don't see much relationship between my writing about this. I'm writing this stuff more as a journalist, but also as a public health person looking at the epidemiology. When I was in my 20s and I was out shouting and screaming and, whatever, protesting, that was kind of a different thing. But at the same time, the parallels are, a community being neglected and their medical condition being neglected. The differences are very stark, though. Nobody could pretend in the 80s or 90s that HIV was psychological. People were dying, so you couldn't, pretend. Nobody liked homosexuals or, heroin addicts and hemophiliacs particularly, so that nobody cared that people were dying. I'm being facetious, but, overall, society did not care that gay people in particular were dying. but you couldn't pretend that they weren't. And the other thing is that people could be very active until they were very sick, and being very active didn't make them sicker. In contrast, people with ME or long COVID, that is the cluster of long COVID symptoms that parallel ME or that appears to be ME. They have post-exertion, a bad term for a serious phenomenon, which is that they after minimal amounts of exercise that would not be a problem for most people, they have serious relapses. That limits the kind of activism you can do. So, and it also, on the same time, people don't believe that they're even sick. So there are, similarities in terms of the social phenomena. I'm not talking about the medical aspects, but between the social phenomena, similarities between the social phenomena of AIDS activism and ME long COVID activism, and also a lot of differences too. That make it harder, in some ways in many ways for people with ME and long COVID to do the same kind of activism and street activity and protests and stuff that were very common in the 80s and 90s related to HIV. So I don't have as much to say about the medical. Obviously both are viral illnesses. Both create or lead to chronic conditions.
Just in relation to what you said about the deaths, I mean, we know ME can be fatal. It has been. We've seen that over the years. It hasn't always been recorded, but moving forward, hopefully we can all finally agree on a biomarker, and the seriousness of this illness can really be seen for what it actually is.
I guess I should modify what I said, especially given light of some recent events, that I mean, people not inevitably, but most people with HIV end up dying if they're not treated. Most people with chronic fatigue syndrome will not die. They will just be sick for, indefinitely. So the fact that we've had, we've had some deaths, that seems to be coming more from the mistreatment and the not proper medical treatment. It's not clear that ME itself is killing people, but the improper treatment that they are receiving is not allowing them, like in the case of Maeve Boothby O'Neill, to get the nutrition that would sustain her life.
Yes, absolutely. There's no specialist NHS care provision.
That's a real problem. Part of the problem is that nobody quite knows what to do exactly. I mean, I think they're just figuring out what are the ways in which to prevent these things from happening.
Okay, to pick up on what David just said about people not knowing what to do, I'm going to voice my concern since reading the NHS e-learning modules, which are supposedly coming out this winter. They currently don't describe PEM, post-exertional malaise, or the risk of exceeding anaerobic threshold. This is key to ME/CFS. They also don't describe how to treat symptoms based on the knowledge we do have about orthostatic intolerance and oxidative stress. Look, since the pandemic, much more about ME and how to manage it is known. The people writing the plan need to keep up. Also, just to add, any safeguarding concerns raised, which so often target the mother, are allegations which need to be responsibly managed. I'm sure you can hear the desperation and urgency in my voice, and this is because of decades of abuse and neglect. Things need to change. Deaths can be prevented. Since recording this interview, I actually had the opportunity to read the statement of Dr. Anthony Hemsley. Since Maeve's death, that trust have considered what improvements can be made to the service in order to improve the care, treatment and service provided to those who present with severe and or very severe ME/CFS. What we need to do is we need to take forward Dr. Hemsley's recommendations from this statement locally, regionally and nationally.
So it's a very complicated situation, but one of the reasons we're in this situation is that so much of the research until now has been starved because so much of the research in ME has gone to these biopsychosocial people to do their crap research. And basically they do the same studies over and over and over again and come up with the exact same bogus findings.
Right, and thankfully there are scientists pioneering in the area of ME. I follow them, Polybio is one of them, and George, this would be the question for you in regards to the cancer. It was only last year a lady with breast cancer twice, who it was following a suspected illness with mono, that's the same virus that caused my illness. I was triggered by EBV, the Epstein-Barr virus, which isn't new. We know it's a driver of cancer. Okay, there's a lot of stuff that isn't new in the science world. It comes out like, oh, long COVID found out this. No, they didn't. It's well known and well documented. But she reached out to a researcher, and they found out she was producing a sort of abnormal amount of this protein called WASF3. And that helps you to make energy. It's how the mitochondria make energy. And the takeaway point, which maybe wasn't so clearly put forward from journalists, because like you said, they don't have a science background. I mean, neither do I. I'm just an actress. But the takeaway point is, when we're talking about mitochondrial or metabolic effects, such as the abnormal amount of this particular protein, it is vital to highlight that pathogens almost always target these pathways and genes.
Dr. Kleiner says she splits her clinical time between two illnesses, one's ME, one's HIV. She said in 2009 she'd rather have HIV. This isn't about comparing illnesses, but we need to understand and appreciate that long COVID and ME can impair quality of life more than advanced cancers. We have studies to show this.
And with it being Cancer Awareness Month for breast cancer, I do think it would be good, George, to talk about, your diagnosis and where you're at with that.
Thanks, Jenny. Well, so one of my big inspirations as campaigning organisers is the breast cancer campaign. It's incredible what the breast cancer campaign has achieved, because, like so many predominantly female illnesses, it had been massively neglected by the medical establishment. And same with ME/CFS. It is mostly women who suffer from it, and therefore it has been neglected. It's as like night follows day. That's the way it's going to go. But, the thing which has changed it with breast cancer has been this incredible pushback from women, both of whom have suffered it and people who haven't suffered it, but are saying we should not be neglected in this way. There should not be such medical neglect. And before I had my prostate cancer diagnosis, I had actually written an article about the power of organizing, where I highlighted the amazing work of breast cancer campaigners in completely turning it around and turning it from being one of the most neglected branches of medicine to a branch which is now taken deeply seriously and that gets much more funding and much more research than it did before. It's a fantastic vindication of organizing and of the amazing and tireless campaigning. So I was talking, for instance, to someone who lost her sister to breast cancer, and it just from that point onwards, it's like she was a breast cancer campaigner, and she was spending every spare moment out, literally shaking the tin, trying to raising money for research, buttonholing people who might be able to influence the research priorities, who might have hands on the pot of money. Just someone with no science background. She was a shopkeeper. That was her job, and was transformed into this powerful super campaigner by this awful experience of her sister dying. And then fairly shortly after that, I was diagnosed with prostate cancer. Luckily, at quite an early stage. I was one of the very fortunate men who had that diagnosis at a point where it was still confined within the prostate gland. It hadn't spread anywhere else in my body. And that's so lucky, because it was a moderately aggressive cancer, but it was caught pretty early. But so often it's asymptomatic until you've got secondaries all over your body, until it's already spread beyond the prostate, and really there's nothing. Well, it's not nothing you can do, but the treatment is very invasive and very difficult and won't necessarily succeed. And for some people, there is nothing you can do because it's already got to the point where you can't be treated before it's even picked up, before there's even a diagnosis. It's really, really difficult. And so I started looking into this and found that part of the problem is that men are really shy about talking about their health, particularly talking about their health in that particular region of the body. And we're a bit rubbish. Men are a bit rubbish in various ways, but we're a bit rubbish about being intimate and talking about intimate health issues in particular. And we are getting better, I think. Still, there's a long way to go. And I realized that what was needed for prostate cancer was a very similar push to what we'd seen on breast cancer, not least to get a push for early diagnosis, because the methods at the time of my cancer were just incredibly crude, hit or miss. You would get blood taken and you would get what's called a PSA reading, which was this chemical in your blood which might show you that you've got a cancerous prostate, but it might not. There's lots of false negatives. There's lots of false positives. But if it's above a certain level, then you might have a biopsy, and then you might have an MRI scan. But it's incredibly complicated and cumbersome, and it's the initial test, which should be a very simple test, is just got a very poor hit rate. And there've been plenty of men who are told you don't have it and who turn out that they do have it. And I'm not blaming anyone for this. It's just there isn't an easy test, but the money hasn't been put in to ensure that an easy test is developed. I mean, lots and lots and lots of money is required to do that, and we are heading very much in the right direction now, and heading towards less invasive forms of surgery and treatment and all the rest of it, which is all again great stuff. It's all heading in the right direction, but what you realize, and this is, it speaks to what you and David were saying, is that advocacy is absolutely crucial. When I was a student studying a branch of biology, the impression given was, well, this is all values free. It's all just completely neutral. We're just, the science speaks for itself and we're just following the science. The science doesn't speak for itself. That's why science journalists exist and unfortunately don't always do a great job. You need that advocacy. And as David says, one of the cruelest ironies with ME/CFS is that energetic advocacy that I saw with breast cancer can be very difficult because of the energy deficit involved in ME/CFS. And so it's this sort of, this trap. It feels like a trap. And I do feel that's why people who aren't sufferers from ME/CFS have to show solidarity with those who are.
I think one of the things that, the Millions Missing campaign has, I think, done an effective job of playing on that, because what they're emphasizing is that these people are missing. And I think what's weird, but when you start covering this, I mean, I had no idea how many people were homebound and how many people were out there being sick because you don't see them. And so I think the Millions Missing campaign and the putting shoes down on, to represent the people missing, I think that's an effective visual a way of representing what's happened here, is that these people really are absent from life because they can't do the things that they used to do. And the other thing I always find so surprising is that these people talk about, biopsychosocial researchers talk about people wanting to fulfill their sick role. That's kind of the term of the sick role. That's a sociological thing. You play the sick role. But the idea that millions of people around the world want nothing better in life, out of life, than to just play the sick role and get attention, it just violates some internal understanding or some internal instinct I have about what people want in life. I just can't believe that millions of people around the world want nothing better or see nothing better than to be sick, and that they're making themselves sick because they want to fulfill their sick role. I just find that an astonishing claim. I just don't get it. I don't get how anybody can see sick people and that's their conclusion.
I think it really needs to be driven home that this whole, you enjoy being sick. Try, as a healthy person, lie in bed for the day, then try it for 2 days, then try it for the week. Don't tell me you've got commitments and work or this, or well, I can't do that because X, Y, Z. All people with ME have X, Y, Z or did have it. Try it. And that's just 1 week, and people are stuck like it for years. And that's why it's disgusting.
So it's, one of the things I've noticed as I've got older is that these recurring themes, these deep ideas, which are often so deeply planted in our minds that we don't even recognize them as ideas. Some of them are centuries old. It's what the brilliant cognitive historian Jeremy Lent calls root metaphors, these ideas which are just implanted in our minds. We don't even recognize that it's an idea. This is just the way things are. And so this notion of being among the undeserving, and you don't deserve treatment, you don't deserve benefits, you don't deserve anything because you are a malingerer, because you're faking it, because you're lazy, you're indolent. That's a very deeply embedded idea, which long predates the biopsychosocial model of ME/CFS.
One of the things that I think has happened is that some of the blame that George talks about on malingerers has shifted. They're not blaming people as malingerers, they're blaming people for unconsciously wanting to be sick. It's like they're not saying people are consciously, lying in bed and saying, I want to fulfill my sick role. They don't know that's what they're doing. So they've moved the motivations from conscious ones to unconscious ones, but in effect, it becomes a similar, you're in a similar position as a patient, whether you're being told you're doing this on purpose, or whether you're being told you're doing this unconsciously on purpose. It's essentially the same thing.
Yeah,
You're
absolutely.
not being blamed in quite the same way, but you're still being blamed.
What I'm trying to say is, these root metaphors create entrenched attitudes which are stronger than evidence. Jen, I'm really sorry, but I do have to go now. I've got a
I've
big
kept you both
family
much
commitment.
longer.
So no, but no.
Thank
Anyway,
you.
it's been
Thank you
great.
very much.
Thank you. It's so nice to talk to you both. Bye-bye then. Take care. Cheers. Bye.
Thanks,
Bye.
David. And thank you for your time. Is there anything that you wanted to add that we didn't get to?
I've really been completely shocked by this story and by reporting on it. It's really shaken me. My father was a doctor, and I grew up with Lancets and New England Journal of Medicine, piles of them around the house. And as a journalist, you're trained that if something appears in the peer-reviewed literature, you can publish it, you can write about it because it's been vetted. And really through this, I always knew that there were problems with that, but through this, I've just realized just how ridiculous, how flawed that system is. And maybe not in every domain. I'm sure it's a problem in multiple domains of science, but in this domain, it seems to be a particular thing with the same people writing and reviewing each other's work and being published in sort of essentially what are how the editorial boards of the journals. And so they're publishing and peer reviewing each other's work, and it's really quite incestuous, and they're all kind of referencing each other. And it's what we call in summer camp, or what we call in the US, a circle jerk. If you know that term, it's a summer camp term. And
I think I do. Is it dirty?
Yes, yes, it's in summer camp, the boys stand around and we jerk off and see who can, it's like what you do when you're 13 or 14.
In England, we call that, I think in England, we call that soggy biscuit. And they do it over a biscuit.
Salted, it could be that, but in American English, just praising each other and referencing each other, and
right,
they're all in an insular world. They have an insular worldview. They don't look outside it, and everything they write confirms what they already believe, and everything their peers write also confirms it. So they're just engaged in a conversation among themselves that really is ignoring the reality of what's going on outside. And the whole thing is this whole story is an incredibly huge circle jerk and an incredibly huge emperor has no clothes situation on the part of the entire British academic and medical establishment, sweeping in the entire academic and medical establishments of the Netherlands, Sweden, Denmark, and in some cases the US. It's really an astonishing story of people who are so blind that they can't see that the work they're producing is absolute nonsense.